Thank you for very interesting presentation, very important. But I had the idea that there was some regression to the mean when you follow patients with extreme levels of biomarkers of 1 year and they are reduced. Then you told about the randomized controlled trial. This is the only way to find out, I think. Do you have funding for this? Are you going to start it? How many patients are you going to recruit for that purpose?
Yeah, no, I totally agree. This is always a worry where you don't have a control group, right? So all these are retrospective examinations of biomarker data on cohorts that have been subjected to these things in a randomized manner. But there is a range of reduction, obviously, when you're looking at thousands of people. Even in the Barry 2D data set, we were measuring this in 1,300 people. So some people it went up, some people these came down. So there's a whole range. Overall, of course, as you noted, there was a reduction. Interestingly, all of these patients, whether they were randomized to intervention or medical therapy, had a great deal of lifestyle intervention, as you probably remember. It was a mega trial in diabetics. And so we really cannot answer that key question that you just asked. However, it turns out that if you separate out those people who had reduction versus those who didn't, the prognosis actually was totally predicted by that. So it's proof of concept, at least, that that's what's happening. The study that I presented to you, Precision CAD, is a small study. It's been funded, so we've just started recruitment. It'll take us a little bit of time. And there are other studies that we're doing in diabetics using the SomaLogic measure as well, which is another proteomic scan to see whether, like you mentioned earlier, SGLT2s, GLP-1s, etc., these sort of more expensive but cardiovascularly more protective agents, when they're introduced in people, particularly at high risk based on the biomarker risk score, not on their glucose and things, would actually not only normalize risk, but also ultimately reduce events. But as you can imagine, these, like all cardiovascular trials, they have to be mega in size to be very persuasive. But I think these are first steps in trying to get over this hurdle where we always end up with residual risk. And the other part of this is, even if you were in a pharmaceutical company or you had a new drug, right? They're all very expensive now. Who do you target it to? We target it to everybody with disease. But actually notice that 40% of them have extremely low risk. They're like population-based risk. These are like 60-year-old people. And there's no point trying to do a trial where nothing's going to happen in 5 years. You want these high-risk people. You can use the biomarker risk score to identify these people. That's where you do the intervention to see whether these things are working. And the additional medicines that we have in these people, often, as I say, more expensive and for increased burden for people swallowing pills, etc., can be directed at that really high-risk population that may only be like 15–20% of the people that we look after.
One more question for you. Now we see emerging new drugs for control of inflammation. Anti-inflammatory drugs, monoclonal antibodies, right. Canakinumab, new drugs for interleukin-6.
Right.
What do you think? Will they come into practice? What is the current state, in your opinion?
Well, as you know, canakinumab, which had a big trial, was abandoned for cardiovascular use, partly because of side effect profiles, but partly because of expense, and partly because the cancer reduction was so much better with that drug that Novartis decided to do that. So I think there is a danger, if you like, in having these new medicines being so expensive to begin with, and then but there will be new ones, and as you just referred to, there is a pipeline of these agents being investigated, and I think targeting in this manner would, if we can get our agencies, in this country, this is Medicare and so on, who actually determine what you get paid for. that allows us to use these drugs. If we can get them persuaded on the fact that you really need to determine high risk. Now, in your presentation, you pointed out how, in a sense, just looking for obesity, which is one way of getting into prevention into people. You say, oh, you overweight. Let's look at your risk factor profile. Let's see if you need treatment for this, that, and the other. So we are always using these clinical entry points to treating people or to emphasizing them to the, yet we have these proteomic things, and there are other biomarkers, of course. Not one thing, not CRP. That's where what sort of put us off the rails is using one biomarker, which was kind of not very exact, and it was very fluctuating, like you said, goes up and down, you don't really know. But when you use a profile of markers, like we look to, you look at blood pressure and diabetes and hypertension and weight and exercise to evaluate risk, you have to look at multiple pathways to totally evaluate risk. And if we can make this kind of evaluation cheap and available and simple, like we do with glucose with a finger stick, and this is all coming, of course, this is all technology, and technology will be there. Then you could imagine how you would be much more capable of identifying risk, and then the treatments will follow, because it will be addressing only people at high risk and not addressing these obese people, like you said, who have metabolically healthy obesity, because none of these biomarkers will be available. They will have no liver fat, for example, et cetera, et cetera.
Thank you so much.